Thank you very much for your kind introduction, Peter. And I have to apologize if some of the slides that I'm going to present to you will look very similar to what Ajahn Prapan just presented to you. It's not just activism that runs in family, but I think all the thoughts we actually could combine these two talks together. So I will try my best to cover these three key topics during this talk. First, I will just only going to talk not so extensively about HIV prevention methods in efficacy trials and interesting options in the future. And then I will talk about double-sided cascade because I would like to convince all of us sitting here that we are working in the HIV field and we should now track our efforts in ending AIDS on both the HIV treatment side and also the HIV prevention side. I will then also talk about the daily PrEP and on-demand PrEP. And then I will end by show to you some great example, exciting examples of PrEP implementation in this region. So during the preparation of my talk, I actually had a chance to do a household survey to ask samples from my own household what they think are ways to prevent HIV. And these are their answers.
I think that you can use condoms to prevent HIV when you are having sex. I think you can also eat the PrEP pill 1 week before you have sex.
And then the next answer.
I believe in the future we could inject dead HIV particles into the human's body before having sex to prevent HIV.
So the best thing to do would be to not have sex, but that would be impossible, I guess. So maybe you could use condoms, which would be a very viable option. However, some people may not be able to use them regularly, or maybe in situations where it is unacceptable. And therefore, I think the next best thing would be the PrEP pill, as this can be taken and acts almost like a condom. However, I think the best thing would be to do both, because that is, better safe than sorry.
And then I prompted them, which other ways you think can also prevent HIV? And these are their answers.
In the future, I hope that people who struggle with dirty needles and contamination will be provided with clean needles, I guess. I can see that in Canada, I think, they're already starting to do this, which I think is a hopeful sign.
Drug addiction is a really hard thing to stop because drug addiction is just like brain addiction. Therefore, I think to solve this problem, we need to introduce more clean needles.
And this is the last answer from a 10-year-old boy.
I think drug addiction is like being addicted to games, like most of my friends.
And not he himself, just his friends who is addicted to games. I feel that if these boys knows that condoms, clean needles, PrEP can prevent HIV, and that a vaccine is like a hope for the future, all of you in this room should also know about this. So it's quite challenging for me to think what I should include into my talk. So I would like to start by just telling some information about these upcoming biomedical HIV prevention tools in efficacy trials, and I'm not going into those in the earlier phases of trials because I don't have enough interest to look into those details, so not enough knowledge to tell you about those tools. So let's start with this once monthly the piperine vaginal ring, which in randomized control trials we have seen an efficacy of around 30% reduction in HIV incidence, and the piperine vaginal ring is now in the open label phase in Africa for women. And we have to learn from this real life use, because adherence, although to this once monthly tool, is again the key factor driving the low efficacy seen in the randomized control trial. So we hope to learn the real life acceptability and use of this vaginal ring. The next one is the monoclonal antibody VRC01 to be infused intravenously every 2 months. This is very exciting and is now in an ongoing randomized control trial phase in MSM transgender men and women in Brazil, Peru, Switzerland, the US, and also in women in Africa. Vaccine are also an exciting phase, and there are two, one planned and one ongoing randomized control trial phase in men and women in Africa. We also have this Discover trial ongoing, which is a randomized control trial to look at oral PrEP, which contains TAF and FTC, so not TDF and FTC. And then we have this long-acting injectable PrEP using cabotegravir, now in active ongoing randomized control trial. And Thailand is also one of the sites here doing the HP10-083 study. And there's also another randomized control trial in women in Africa. These are also some interesting tools, not in the efficacy trial, but I think it's interesting enough to share the information with you. MK8591 or FDA, the nucleoside reverse transcriptase translocation inhibitor, to be taken orally once weekly, have demonstrated 100% protection among macaques who receive repeated intrarectal shift challenges. And PrEP implant is also another interesting, innovative way to deliver PrEP medication into our body. And implants being studied includes those which is biodegradable, those which is mini pump, acts as a mini pump to deliver an exact amount of drugs into your body daily. And the PrEP medications contained within the implants include cabotegravir, dolutegravir, TAF, or TAF and FTC. Now I'm going to talk about the double-sided cascade, because many of us here as a clinician, we tend to focus more on the treatment side of the cascade. We want to diagnose people, put people on treatment, and then make sure that they achieve undetectable viral load. However, in order to end AIDS, I think that we have to also give equal importance or focus on the prevention side of the cascade as well, to make sure that people who are already coming to you for HIV testing actually receive a full prevention package and use them effectively, use them wisely, and come back to you for HIV retesting and remain negative. That's a very important role of us being HIV healthcare workers. And this is an example, the actual example from our test and treat cohort conducted in 2012. We have been successful in putting 86% of people on ART, and then having 82% of them retained in ART program at 12 months, and 93% had undetectable viral load. However, on the prevention side, you can see here that over a year, only 81% came back for HIV testing, and only 75% at 12 months are those who we know that they remain HIV negative. And among those who came back for HIV testing, we can see a different proportion of people who use different prevention tools. 59% here use condoms, 7% use PEP and condom, 3% use PEP only. So it would be important in the future for us to track changes of these proportions of people using different prevention tools over time, so that we can plan more effectively or better plan on how we should create demand and supply to support the most effective use of prevention tools. And even though you may be a treating doctor, mostly work on the treatment side of the cascade, it means that you are already doing HIV prevention, because as Ajahn Prapan mentioned, we all know treatment is prevention. We all know undetectable equals untransmittable. However, have we been doing work effectively enough? Have we used our best efforts to try to make this prevention effect of the treatment be seen as quickly as possible? Can we actually start people on ART on the same day that they have their HIV diagnosis? Have we been doing the task shifting work very effectively in order to allow doctors in the hospital to see sick people and then channel out those healthy patients on stable ART to be seen by nurses or by community health workers? We have to really think about this more seriously if we are going to say that what we are doing, the treatment is already prevention. And I'm not going to cover all those treatment things, because we have been hearing from Dr. Prapan already, and we'll be hearing from many other speakers throughout these 3 days. So the focus will be on the prevention side of the cascade. And I know that everyone is very familiar with condoms, lubricants, needle syringes, risk reduction counseling, harm reduction, the using of combination HIV prevention package, and also PEP. What I will be going into more details will be daily prep, on-demand prep, and also to talk a bit about the key population-led approaches, which I think is the key for the prevention work. Let's start with daily prep. I have no new data on the effectiveness or the efficacy of PrEP because everyone knows that PrEP works if used correctly and consistently. There's nothing new. And up to now, there have been 4 cases of PrEP failure reported among around 150,000 PrEP users globally. One case is likely a true PrEP failure. Another case is a case who acquired HIV because of the exposure to multi-drug resistance virus, and another 2 were MSM who took tenofovir for Hep B treatment, so only tenofovir without FTC, and then got infected. Drug resistance, there is also nothing new about drug resistance and PrEP, but I think I would want to touch on this because I have heard over the past year that a few PrEP providers in our country stopped providing PrEP after hearing a lecture from an ID physician telling the audiences that PrEP will increase the number of drug resistance in our country. No, so I think this is something that we need to make it clear. What is really the fact? What is just the hype or the unseen concern among the physicians here? So just to remind everyone, drug resistance only develops when there is HIV infection and when there is prolonged dual drug exposure. So only a subset of PrEP users who have unrecognized acute HIV infection or who have inadequate adherence and then seroconvert and do not come for regular HIV testing will have the potential to develop drug resistance. So not every PrEP seroconverters will have drug resistance. So let me use some visual example to show to you here what's the expected impact of drug resistance and PrEP use. So in a setting without PrEP and with an incidence of HIV of around 6% per year, we would expect to have at least 5% transmitted drug resistance among new HIV cases, represented by the red dots here. And new drug resistance, while people are on ART, will be increasing. So let's add another 5% represented by the yellow dots here. And at the same time, without PrEP, the next year, you will also have another new set of HIV cases with transmitted drug resistance. So the dots, the red dots, the yellow dots here represent the number of drug resistance you will see in a setting where there's no PrEP. With PrEP, even if we have a subset of PrEP users who do not have who have imperfect adherence, the total number of new HIV cases will be dramatically reduced. And assuming that 20% of PrEP seroconverters develop drug resistance, and I'm not optimistic here because we see the maximum of only 20% drug resistance among PrEP seroconverters in clinical trials. We will see these red dots of people who are PrEP seroconverters with drug resistance. But each year, we also know that people who are infected will then develop an additional drug resistance while on ART, and that is represented by the yellow dots because there's only one dot on this side because this happened in a much lower number of HIV cases, not like the number of total HIV cases on the left side, as well as we will have a much smaller set of new HIV cases. So at the end, you can see here that with the wider use of PrEP, we will see a lower number of HIV drug resistance cases, not the increasing number. Okay, and the modeling actually suggests a much lower prevalence of drug resistance among PrEP seroconverters. I used 20% in my last slide, but the modeling studies suggest that only 1 to 8% prevalence of resistance among PrEP seroconverters when PrEP was used for 10 to 20 years. Okay, so this is a much smaller proportion. So what you have seen in the previous slides is actually the most pessimistic scenario that this will happen. So our role is not to avoid giving PrEP because of the fear of creating drug resistance, but our role is to better screen for acute HIV cases, to better support retention and adherence in PrEP programs, and to better establish systems for an easier, better HIV testing, including self-testing. Then what about PrEP and increased STI? You may have heard about this a lot, about being on PrEP and then you've seen increased rates of STIs. We have to realize that high rates of STIs have been observed already among key populations before the implementation of PrEP. And this is the global scenario. It's not only in certain settings or certain countries. And we know that PrEP, if implemented successfully, will bring more high-risk people to us. And then we test them for HIV, we test them for STI, so we see more STI. However, we also know we are not too optimistic. PrEP users may decrease condom use, and that may also increase STI. However, the CDC modeling indicated that although we may see increased rate of STI at the beginning phase of PrEP implementation, at the end we will finally reducing the number of STI cases because people are coming out for us for screening and then for treatment. So we also have to know that STI do not undermine PrEP efficacy. Okay, so our role here is not to avoid giving PrEP because of the afraid of increasing STI in your setting, but to better identify and establish a good STI screening and treatment infrastructure, which sadly in our region is still something that is very weak. Now let's move to on-demand PrEP. The IPERGAY study demonstrated that by the use of 2 PrEP pills through to 24 hours before sex, followed by 2 daily doses of PrEP after the last sex, can give you 86% reduction in HIV incidence in the randomized controlled trial phase, and can give you 97% reduction in HIV incidence in the open label phase. And the median number of pills used here is 18 pills to cover 10 sex acts per month, or that equals 4+ pills per week. So the concern, there has been a concern that will on-demand PrEP be effective among MSM with infrequent sex? So the IPRGay team did a subgroup analysis focusing on the person time between visits when PrEP use was systematic and less than 16 pills per month, as represented by the green sections of the person time studied in the IPRGay. And they found 100% risk reduction in HIV incidence with the median number of pills used of 9.5 pills per month to cover 5 sex acts. So in summary, this is some data to confirm that on-demand PrEP is an adequate alternative to daily PrEP for MSM with high risk but infrequent sex. And I think that during the discussion in yesterday's PrEP consultation meeting, we cannot avoid talking about on-demand PrEP. We cannot say that our country, our guidelines will only mention about daily PrEP because we don't want to confuse providers, because it's not the providers that will be confusing. The clients will coming to us asking about on-demand PrEP, and by hiding this fact, you actually are destroying PrEP service delivery. The Amsterdam PrEP project team also explored the reasons why MSM choose or switch between daily PrEP and on-demand PrEP, in which I think that the future of PrEP program will go into this way. We have like a flexible or changeable PrEP regimens for clients to choose from. And they found that for those who choose daily PrEP, the main reasons is around their perceived adherence ability. So those who needed daily structure will likely to choose daily PrEP. Those who, and also the pattern of sex is a key factor for someone to choose between on-demand and daily PrEP. Those who think that their sex are usually unplanned or they have frequent sex will likely to choose the daily PrEP. However, among those who choose the on-demand PrEP, it's also the sex pattern as well. Those who think that their sex is usually planned, they have infrequent sex, will likely to choose the on-demand PrEP. And also the toxicity and the concern around the burden of taking pills are also the main reason why people would choose the on-demand PrEP. And now, let's move back to real world. Ajahn Prapan has already demonstrated a very great example from New South Wales. And I also would like to show to you a few other examples of big cities where we started to see the declining numbers of new HIV cases in London, in San Francisco, in New South Wales. What we learn here is that in these 3 settings, it's not only PrEP that is causing this declining of new cases, but it's a very balanced combination of frequent and easy HIV testing, of rapid ART initiation, and with PrEP. What we also have to learn from these examples is that getting to 90 will not end AIDS. 95, you still will not end AIDS. And until 100, you will need PrEP, okay? And so move to our region, the Asia Pacific region. Around 20% of new HIV cases in our region are happening among MSM and transgender women, 13% among people who inject drugs, 5% among sex workers, and 24% among partners of these key populations. These are key populations with 10 to 49 times higher risk of acquiring HIV. So what we have to think now is that have we worked closely enough with these populations when we design and when we deliver HIV services? We have seen this number already. In Thailand, we started PrEP program with the fee for service. PrEP, or you may know the PrEP 30 program at the Thai Red Cross Mass Clinic. And then we expanded the PrEP programs into PrEP implementation research. And this is to test the model, the service delivery model of key population-led PrEP model or the government-led PrEP model, which both models are scaled up later on into the Princess PrEP program run by key population clinics, and then the PrEP 2 Start program run by the government hospitals. And you can see here, as Ajahn Prapan pointed out, 80% of all PrEP users right now are receiving PrEP either through the fee for service PrEP program or through the key population-led program. And both programs use the same day PrEP flow, so similar flow. When you have people coming in for HIV testing, tested negative, discuss about PrEP, agree to be on PrEP, that person can receive 1 bottle of PrEP out of the clinic with them without coming back to get the prescription. And then a few days later, 1 or 2 days, they will get a call from the staff telling them about their creatinine clearance level, telling them about hepatitis B serology, and to advise them whether they can continue or discontinue PrEP. And I think so far we have seen less than 0.5% of people who need to stop or to discontinue PrEP due to their kidney function. We have heard about this already. PrEP is something that I think this key population-led health services model will be the key to the scale up and to the success if we would like to scale PrEP up to the level that we see the impact on new HIV cases. Because in this key population-led model, it is very important that you can ensure that PrEP will be provided to clients in a non-judgmental way. That is the key of provision of prevention tools. And as well as the operating hours of these KP-led clinics, which will usually happen in the evening or even in the late night hours, that really serve well with the populations who are so in need of PrEP. We have also seen that this key population-led model can successfully identify people with very, very high risk of getting HIV, with a very high HIV incidence. So surely the most likely PrEP targets for the country. And we have seen that right now we have around a bit over 6,000 PrEP users in the country. Even though we have regular attacks and threats towards PrEP program, towards the service delivery model of PrEP. Many of you may think that, oh wow, this is an inspiring number. Many of you may think that, okay, it's a good number. Some of you may think that, oh, it's better than nothing, depending on where you come from and who you are. But for me, I think this is a number which shows that we are much, much too slow in scaling PrEP in our country. We have a size estimation of MSM in our country to be 500,000. And we all know this is underestimated number already. And if we assume that 20% of these MSM are high-risk MSM who are PrEP target, we would need to provide PrEP to 100,000 MSM. And right now, we only reach 6,000 MSM. Many of them are non-Thai through the fee-for-service PrEP clinic at Pulse. However, I also would like to share with you some exciting examples from a few countries in our region. Taiwan has successfully launched and implemented Taiwan CDC PrEP demo project in October 2016 and have enrolled 302 people by August last year. The clinic visits and lab tests are free. But PrEP is not free. PrEP is subsidized partially. And you can see here that Taiwan program also was attacked by the anti-LGBT group, which caused the halt of the program in July 2017. But they turned this into an opportunity to then explore how generic PrEP drug can be delivered into their country, and then to monitor the proportion and number of PrEP users in Taiwan who can pay out of their own pocket. You can look at this as an optimistic example, or you can look at this as a way that you will have to be prepared of the challenges that you will face when you start implementing PrEP program. Vietnam has also successfully launched and implemented the P4P pilot model. And in this model, it is a fee-based service. But the PrEP service, the PrEP counseling, HIV testing are delivered by KP-led clinic. As well as the prescription of the PrEP to be delivered, to be prescribed by KP and non-KP clinicians in KP-led clinic. And you can see here that just over 10 months, almost 600 people are already enrolled into this program, and it is successful. The country saw this as a successful program that it started to integrate the model into the public health sector. So this is just some examples from countries in our region, and I hope that next year we will see more and more examples, and probably some of you there in the audiences may be standing here telling you your great example and great stories. So in conclusions, I think that countries in our region are not doing well on the 90-90-90 targets, especially among key populations. But yet, we are not sensing the urgency of PrEP implementation and scale up. And for me, this is very scary. As healthcare professionals, we need to take courage and be open-minded to truly implement combination HIV prevention packages. And this does not mean condom only, PrEP only, but it's combination HIV prevention tools that you package it into something that you offer to your clients. And to fully engage key populations in the design and in the delivery of HIV services. And this is not only about MSM, transgender women, sex workers, people who use drugs, who inject drugs, and youths as well. And as government policy makers, we should stop talking about giving this HIV prevention package, engaging KP, just because these are keywords, one have to say, but we really need genuine action and engagement in order to improve the health infrastructure, to establish the financing mechanism, legalization mechanism, in order to allow services to be delivered by key populations for its sustainability. And I'd like to thank our funder and our partners who make the work in our region possible, and also to Dr. Stefan Koo and Dr. Kimberly Green, who allowed me to share their exciting examples from Taiwan and Vietnam. Thank you very much.